So what's the pattern like? The British Crime Survey, the latest one, 2009-10, shows that actually the levels of Class A drug use in London in the previous year are coming down. In fact, they're a little bit below the national average for England and Wales. We can't be complacent though. Trends are just trends. We don't know what that means. The BCS is not, it's a bit of a blunt instrument when it comes to epidemiological data, of course. And also, interestingly, and that's, I suspect, why we have colleagues from other regions coming to tell us in London about what they're doing. London has been overtaken by North East and North West regions over the last 15 years in terms of drug use. However, some of the alarming figures, just to build on the figures that were given earlier on by David and Geraldine, that it's estimated the Hepatitis C Trust report in 2010 showed that maybe 53,000 people have hepatitis C, of which only maybe 7,500 are diagnosed. Massive hidden morbidity, massive hidden future mortality, massive suffering. So we have the hidden harm, not the hidden harm of the children of drug and alcohol users, but the hidden harm of the tip of the iceberg below the waterline. So NHS London Titanic is heading towards the iceberg when it comes to hepatitis C. And the all-parliamentary hepatology group this year in the DART report, there's a worrying shortage of basic monitoring in hepatitis C services, such as numbers of patients referred, numbers offered treatment, numbers initiating treatment, and treatment results. Basic information, again, really referring to the need for better IT systems. Certainly if we're trying to move towards payment by result or payment by outcome, if we don't have the IT systems, it won't work. Well, we won't get the money. The rising tide, nationally, we see that the rising tide of deaths in men and women is continuing. This is yet another rising tide, whether it's the rising tide of health problems in people with severe and enduring mental illness, or rising tide of hepatitis mortality, so infection and indeed mortality. We've got to face the challenge though. And again, these are Health Protection Agency figures, and I'm worried that HPA, very worried the HPA is being abolished, and hope that those functions could be entirely taken over by local public health services. However, I am concerned. There's a rising tide of number of people with decompensated hepatitis C and decompensated cirrhosis, light green, and also compensated cirrhosis, those that may well become decompensated in the future. The trend is clearly an increasing number, and we have done nothing to decrease that trend over the last few years, since 1995, and projected for the next 5 years to 2015. And I think addiction services have a key role in that. We have to grasp the nettle. We have to be allowed to grasp the nettle, and we have to be supported in terms of facilitating the movement of patients between hepatology services and addiction services much more easily than hitherto. Yeah, there is movement, and people generally come into hepatology services. You can see it's an array. It's a lottery, isn't it? No names, but there are many London acute trust hepatology services in that. The people that actually engage and are offered treatment when they come to hepatology services with people with hepatitis, essentially requiring treatment, and there's a massive difference between 30% and almost 100%. In fact, 100% reported in some cases. So some services are getting it right. Others maybe are not getting it quite so right. In fact, probably others are getting it really wrong. So when addiction services interact with hepatology services, we have to be aware of mutual strengths and weaknesses. And that's more difficult as services change rapidly. Instead of trying to populate my map of London with different figures regarding addiction services, voluntary sector services, etc., I thought I asked a number of people, so I thought I'd get some of their thoughts. So the loss of bloodborne virus BBV specialist focus and dedicated staff has damaged addiction services response to hepatitis C. By the way, I've sanitized some of these quotes, just for those who are nervous or polite disposition. But they are exactly what the people said. I read them out. I said, is that okay to be at a conference of colleagues? 1/3 of the boroughs we serve support the provision of dedicated BBV staff. The others said it should be fully mainstream in addiction services. So clearly there's a different understanding, even within a single overarching addiction service within the Mental Health Trust. The drive towards recovery in addiction may result in throwing away the BBV baby, the bloodborne virus baby, away with the presumptive bathwater. Don't do that. This is the jewel in the crown, really. The opportunity of promoting, minimising the harm of people in addiction services. This is very telling. Even crossing the car park from the opioid treatment clinic to the hepatology services can be a very long and tortuous journey. So even if it isn't 2 buses and sitting in a busy waiting room and feeling awful, be worried about it, depressed, maybe, certainly sort of feeling, I don't want to do this, but I feel I need to. Even crossing the car park is difficult. So the idea of standing alongside people is very, very important as they make that journey from addiction service to hepatology service and back again. Some hepatology services cater better than others. I think that's clear from the treatment lottos. The Great Divide. Addiction services in London have diverged from acute hospital trust for over 15 years. When I started with my community drug and alcohol team, the beds were on an acute hospital site and the clinics were on an acute hospital site. We also had satellite clinics, but that was our base. And of course that was seen as institutionalised. Unfortunately, I think institutionalism is something that's in the mind, it isn't in bricks and mortar. But anyway, that was how it was seen. So we moved out, and of course the rate of people referred to hepatology services and succeeding in being engaged by hepatology services, hepatitis C, decreased massively, less than half previously, when we're on the same site. So even though they had to cross the car park, with support, they could do that and even come back. And opioid treatment clinics have been commissioned on the basis of treatment retention and harm minimisation. And that's something which, maybe detracts from the bloodborne virus focus in some areas, unless there's a particular interest. And even in some boroughs, concurrent alcohol problems and mental illness are managed completely separately. So there's even more fragmentation. So somebody with an alcohol problem, an injecting drug problem, plus also hepatitis, maybe managed by a range of services. Services can work together. So I'll just finish. Hope springs eternal. Payment by outcomes could be an opportunity. We've got to consolidate after all this chopping and changing. Having a general nurse is important. And also the London Drug Dependence Consultants Group, which has been going for donkey's years, might be a useful vehicle for helping to draw together some of these issues. And of course we support the conclusions, recommendations of In the Dark. As addiction services, we feel that all these features are crucial to delivering consensus. Thank you.